This is Nicole Freeland, and today we will be discussing Chapter 33, the urinary system. Objectives for Chapter 33. You should be able to review the anatomy of the urinary system, differentiate the causes of urologic disorders, develop a nursing plan of care for a client with a urologic disorder or problem, and discuss common urologic problems including signs and symptoms, treatment measures, and nursing considerations. First, we'll briefly discuss the anatomy of the urology system, or the structures of the urologic system. These are made up of the kidneys, the ureters, the bladder, and the urethra. The nephron is the functional unit of the kidney. The bladder serves as the reservoir for urine. And in women, the urethra is only 3 to 5 centimeters in length, whereas in men it is 20 centimeters in length. So who do you think is more prone to UTIs, men or women? Women will be more prone to UTIs due to their shortened urethra. So here we see the nephron further broken down so that you can observe the different microanatomy of a nephron. This includes the glomerulus, which consists of networks of capillaries that are encased in a thin wall sac called the Bowman's capsule. And then it includes the tubular system. So we see the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule. The tubular system of the nephron is the collecting ducts for urine, and then the urine is carried from there through the ureters to the bladder. So what are the functions of the kidneys? The kidneys work to regulate serum electrolytes. They maintain the acid-base balance within our bodies. They help to eliminate metabolic waste. They regulate fluid volume within our body. They help to regulate blood pressure by secreting renin. They secrete erythropoietin, which increase red blood cell production, and they help to metabolize vitamin D into an active form. So different causes of disorders of the urologic system can include bacteria that can colonize in the kidney or even the bladder, leading to infection. Then we have different autoimmune inflammatory reactions that can occur that result in glomerulonephritis, which damages the semi-permeable glomerular membrane and interferes with normal kidney functions. Tumors can form in the kidneys, the bladder, or the ureters. Certain medications can lead to urologic system toxicity. Heavy metals such as mercury can chemically alter the glomeruli. Hypertension itself can damage the urologic system, leading to eventual atherosclerotic changes to the blood vessels that will lead to decreased blood flow to the kidneys and eventual reduced kidney function. And then also individuals with diabetes can experience disorders of the urologic system because it can cause changes to the blood vessels, leading to blood flow changes to the kidneys, which eventually reduces kidney function itself. So what can we do to prevent different disorders of the urologic system? First of all, the main thing that you can do is encourage your patients to drink adequate amounts of fluid, specifically water. An individual needs 2,000 to 2,500 mils a day of water just to keep optimal flow throughout the urinary system. We need to encourage our patients to empty their bladder frequently to prevent stasis and prolonged exposure to toxins and carcinogens. We can also encourage increasing fluids to 3,000 to 3,500 mils a day when they are on urologic toxic medications such as sulfa compounds or doxycycline and rifampin, which are also nephrotic or nephrotoxic and cause chemical alterations of the glomeruli themselves. And then we also need to educate and encourage our patients to maintain a normal blood pressure level and normal blood glucose levels. All right, so some different diagnostic tests and procedures that are done to detect disorders of the urologic system include a urinalysis with culture and sensitivity. We may do a CBC draw, a blood urea nitrogen or a BUN level, serum creatinine and creatinine clearance, and then a uric acid level. This will measure the end product of protein metabolism. We also want to ask our patients about purine-rich food intake, such as liver, kidneys, or sardines that people may frequently eat, and then we need to educate them over decreasing those foods in their diet if necessary. What is a normal BUN level? Normal BUN level is 10 to 20 milligrams per deciliter. And then a normal creatinine level is 0.5 to 1.2 milligrams per deciliter. And so if it is greater than 1.2, your patient is possibly experiencing kidney failure. A KUB may be ordered. This is a scan of the kidneys, ureters, and bladder. It's used to locate stones and detect structural abnormalities within the urological system. A balloon angioplasty may be performed. This is used to open blocked vessels and increase flow to the organs or the blood flow to the organs. A renal biopsy can be performed. This is used to locate lesions, detect certain cancers, or to evaluate kidney transplant rejection if that's a possibility for these patients. And then it's important to know post-procedurally after a renal biopsy, your patient needs to lie flat for the first 6 to 24 hours. They should avoid activities that increase abdominal pressure, including coughing, sneezing, laughing. If your patient does need to cough or sneeze, you need to encourage them to splint their abdomen with a pillow to help decrease that abdominal pressure to that area. You can expect blood in the urine for the first 24 hours. So if you are going to have a patient that has blood in their urine, what is something you can do to intervene for these patients to help decrease that hematuria? You can encourage your patient to increase oral fluid intake. You should probably encourage them to drink at minimum 3,000 mils of fluid so that that urinary system can be flushed thoroughly. Another procedure that may be performed is a cystogram. These are radiographs that are taken before and after sodium iodine is instilled into the bladder through a urethral catheter. Before the procedure, you're going to want to check for allergies, especially to iodine-based dyes. They'll be given a clear liquid breakfast on the day of the test, and then they are MPO after that. A Foley catheter is inserted into the bladder before the beginning of the procedure. And then it's important to know that after the procedure, you need to encourage oral fluid intake by offering 4 ounces of water every hour for your patient. Bladder scans can be performed by practitioners, including the LPN. This is a non-invasive method that's used to measure post-void residual volume or urinary retention itself. So this is a portable handheld scanner that uses ultrasound to create an image of the bladder, and it calculates the bladder volume. So to perform this procedure, you would palpate the symphysis pubis and then apply gel about 1 inch above that pubic bone. And then you point the probe toward the coccyx area and you press the button for a readout. Another diagnostic test that can be performed is a 24-hour urine collection. In older adults, the kidneys have less ability to concentrate urine, which predisposes the client to dehydration. So we need to carefully rehydrate by encouraging several ounces of oral fluid every 1 to 2 hours. So like I said, 4 ounces every 1 hour. So some nursing management for these patients. We're going to want to get a thorough history at the present time of illness. We'll do a physical assessment, daily assessment of urinary output. So we want to measure the INO, evaluate for abnormal flow of urine. We need to note the character of the urine, so the color, the clarity, the smell of the urine. Is it strong or not strong? And then changes in pattern of voiding. So if they have decreased urinary output, what could be going on with that situation? We need to figure out why they would have decreased urinary output. Caffeine and other diuretics found in drinks and food. Increase in fluid intake can increase the number of times a person must urinate. So if you are trying to get your patient to void after a procedure, you can offer them caffeinated beverages, take them to the bathroom frequently, just to help increase the number of times or to help them urinate after this procedure. You can turn on the tap in the bathroom to help them urinate. You can offer warm baths to help them urinate. And then you also need to assess their pain and discomfort and then treat that accordingly. Along with that, we would monitor vital signs, lung sounds, and respiratory effort. And why would we monitor lung sounds and respiratory effort? We would do that to monitor for fluid retention. So if your patient is having problems voiding and they are retaining fluid, they may experience respiratory difficulty. They may have edema, especially to their lower extremities. If we notice any of these signs or symptoms, we need to call the practitioner immediately. Hematuria we kind of talked about earlier. So after certain tests, including a renal biopsy or a cystogram, maybe they may experience hematuria or blood in their urine. If this is noticed as soon as the void starts, it's likely from somewhere in the urethra itself. And then if it's actually noticed at the end of urination, the site is probably near up into the bladder or even towards the neck of the bladder. Proteinuria is just protein in the urine. This is suggestive of damage to the membrane that occurs in the renal tissues themselves, which is a sign of renal disease. So we would want to educate these patients to limit their protein intake to about 3 ounces per serving with meals. And then pneumoturia is actually gas that is found in the urine. This is found when there's often a fistula or a little abnormal passage between the bladder itself and the vagina or the bowel. And so something that you will see often with these patients is gas or bubbles in the urine. And then other terminology that's related to urine output and flow, you can see on page 777. These include inuria, which is just the absence of urine, oliguria, which is diminished or abnormally decreased urine flow, polyuria, which is abnormally high, and diluted urine output, and then nocturia, which is urination that occurs frequently throughout the night. So let's discuss some urinary catheter and tube care. This is on page 779 in box 33-3. But we will want to observe the tube of the catheter itself and then output with the characteristics. So what does the urine look like? What color is it? Is it cloudy? Is it clear? Does it have particles? Does it include mucus within the urine? All of those things need to be noted and then charted. We need to make sure that we keep the collection bag below the level of the insertion site. So the collection bag itself needs to be lower than that of the bladder. And why would that be? We would want to prevent backflow of urine back into the bladder, which would introduce bacteria into the bladder, which then leads to UTIs. Perineal care or perineal care, it needs to be performed twice a day. Soap and water used to wash around the meatus, and then you wash out away from that meatus down the length of the tube so that you're not introducing or pushing bacteria up into the urethra itself. Sometimes we may need to irrigate the tubing of the catheter if they have high amounts of residual within their urine or it's very mucousy. Sometimes that catheter needs to be flushed. So you would follow your agency's protocols or your specific practitioner's orders. You would use the correct amount or the ordered amount of sterile solution and then draw that up into your syringe. And then once you attach your syringe to the urinary port, you use a steady, gentle stream to irrigate the catheter, avoiding pressure that may traumatize or cause discomfort to the patient. You should never pull back forcefully on an irrigating syringe because this can cause damage to the tissues or collapse the tubes themselves within the urinary system. Also, you need to know that you should never at any time cut the catheter tubing to discontinue a catheter, as this can lead to further damage of the catheter itself, causing damage to the patient. Also, it's important to note that a person should have at least how many mils output of urine hourly? The answer is 30 mils per hour. So some common urologic problems that can be experienced, especially as an individual ages, include urinary incontinence. Signs and symptoms may include involuntary loss of urine when there is a strong urge to urinate. This is called urge incontinence. And then we have stress incontinence, which occurs when the urethral sphincter fails and there's an increase in intra-abdominal pressure. caused by things like sneezing, laughing, coughing, or even exercise or lifting, anything that weighs heavy at all. Stress and incontinence can be treated with vaginal weight training. This can be ordered by the practitioner. There are combs with strings attached to them that have certain weights, and the female is encouraged to use the lightest weighted cone first. They insert that into the vaginal canal, and then it's held in place by muscle tightening or Kegel exercises for 15 minutes at a time, twice a day. They can also be prescribed a pessary. This is actually a stiff ring that's worn in the vagina during the day. It's weighted as well, and it supports the bladder. This is a bit of an older option, so you're not going to see it used as much as, say, the vaginal weight training that might be ordered. And then also surgical intervention may be necessary if the more conservative methods are not effective. Nursing management for these patients would include correcting the underlying cause itself. You may attempt to assist the client with setting up a voiding schedule, so they need to then go to the bathroom every 1 to 2 hours to help avoid incontinence. And this really does take the patient's cooperation and them being very persistent with their schedule to see any kind of results at all. When you go to make patient assignments, which may not be your task as the LPN, but you may have your CNAs or unlicensed assistive personnel that may be assisting you with your cares for your patients. You can ask the CNAs or the UAPs to record and report any fluids offered and consumed, as well as the number of times the clothes, the bed linens, the pads were all changed as well. And they do not need to create or teach a voiding schedule themselves, but they can adhere to that schedule that you've created and help to assist the patient to the bathroom on that schedule. Urinary retention, or when the patient is just unable to empty the bladder fully, can be caused by different things such as prostate enlargement that we see in the aging male. We can use different interventions to help patients be able to empty their bladder fully. We can offer caffeinated beverages, a warm bath, a double void where they void, they sit on the toilet for several minutes, and then we have them void again. We can schedule, again, trips to the bathroom every 2 to 3 hours. Or we can even obtain order for catheterization if all other measures don't relieve the problem. But we do need to try the less invasive methods first before we receive an order for a urinary catheter. So to develop a nursing care plan for your patient, you're first going to assess your patient. You're going to receive a thorough history, followed by your physical assessment. You will then make your nursing diagnosis to help plan patient care, which in planning you implement your plans to assist your patient with their specific needs, and then you can evaluate your nursing process and change as needed for your specific patient. So, what have you learned today? I would like you to answer these 4 questions after you review these slides and submit them to Moodle. by Thursday at 12:30. So this coming Thursday would be the 3rd. So December 3rd by 12:30, you need to have the answer to these questions submitted to Moodle. And then you can follow this slide with chapter 34, and we will test on these sections next week. Thank you.